Welcome everyone to our monthly SimCity rounds here at the Temerty Faculty of Medicine, University of Toronto. It is with great pleasure that I will introduce our presenter here today, who is an external, we've extended an external invite to Dr. Andy Teodorczuk, who practices as a consultant old age psychiatrist and is the Director of Clinical Training at the Prince Charles Hospital, Brisbane, Queensland, Australia. He is also an adjunct professor at UQ and QUT. Since 2023, he's the president of the Australasian Delirium Association. His research expertise is in educational approaches to best delirium practice. He has a keen interest in interprofessional education, work-based learning, and well-being. Andy has a well-established track record with over 100 peer-reviewed publications. He has received numerous awards in recognition of his teaching and research, including the Principal Fellowship of the Higher Education Academy, PFHEA. Thank you so much for making the time today, Andy, and I'm going to give you the floor.
Oh, thank you very much, Petal, and thank you very much for the kind invite to speak to Canada. I do have a little bit of a soft spot for Canada. I did my elective in the 90s at McGill in Montreal, and one day I'd like to go back and see how it's changed since then. Right, so the first challenge is I'm going to try and share my screen. So this is, bear with me.
I'll give you a thumbs up so you know we're seeing it.
Okay, SimCity final. This is the important button, the share sound. Share. And then we go to... Here we
All
go.
good.
All good. Excellent. Good. Okay. So my name's Andy Teodorczuk, like Petal says. I work 2 days a week as an audit psychiatrist, and really by background, I'm an education researcher. I'm going to be talking to you today around the use of AI and virtual reality in teaching undergraduate geriatric healthcare education. And in essence, I've kind of, over the past year or so, found myself increasingly interested in these two topics because I see that there's a future for sort of achieving high quality teaching. And I was invited to talk at the British Geriatric Society in May in Birmingham on these topics. And this talk is based on these, if you like, just to say that I approach these topics as perhaps as a critical amateur. I'm an enthusiastic amateur. I'm in no way a expert. However, through my reading, I really do see the potential to actually improve. I'm also on X as well. Okay, in terms of disclosures, in the past 5 years, I've received on an area from MIPS, which is a medical indemnity company, and I do have a wellbeing interest. And just to say that I do work closely with junior doctors and really encourage them to get medical indemnity. But perhaps more important for this talk, I'm the president of the Australasian Delirium Association. And what does that mean? Well, it means basically that many of the areas that we're going to talk to are dominated by delirium, and also it means that I like to invite you to our annual conference. Well, sorry, it's every 2 years, which next year is being held in Cairns. Cairns is a lovely place, famous for the Great Barrier Reef, rainforest, and other enjoyable activities. And I'm really delighted, Petal, that you're going to be coming, and together we're going to be doing an AI symposium. With Esther O as well. Esther is a leading American deliriumologist too, but it's not very far to get to Australia, but well, it is actually very far, but it's worth the visit. So cordially invite you to come there, and there may well be online aspects too. Other disclosures, well, look, I've recently started disclosing when I use ChatGPT, and I've used ChatGPT to purposefully develop one component of this talk to structure the talk, and I'll highlight this in particular, and also used AI for some of the images. Okay, so I'm over to AI in medicine. So look, obviously, as you're aware, this is absolutely transformational. has been described a bit like the arrival of a stethoscope for the medic. And really, this is demonstrated by the literature in the area. There's a study by Gordon, which is produced in Medical Teacher, a scoping review that looked at AI articles, and I'd refer you to this, and it shows a exponential rise, as you can see, since 2018 in AI topics. What's really interesting is there seems to be this kind of like arms race between OpenAI, Google, and other approaches too. And every kind of month, something really comes forward, which puts one above the other one. Such as, for example, this article here that says Google AI has better bedside manners than human doctors, which is really interesting, and we'll come to that in particular. So, thinking about AI, it's really important to start with definitions and where we work. We have a professor of AI at the University of Queensland called Tim Miller, and I had a good discussion with him earlier in the year. And his definition is that AI is essentially a subfield of computer science that studies how to automatically program computers to automatically solve problems. And that's his definition. It's been around for a long time, obviously, with sat nav and other aspects too, but really it's taken off now with the arrival of LLMs, large language models. And I want you to hold that thought, if possible, about problems, because we're going to come back to that. In the article by Gordon that I referred to you, they describe this really interesting kind of sort of parallel with the adoption of AI. And they relate this to Obermann's culture shock theory of what happens when people come to a new country, i.e. there's some kind of a cultural change. And that's what we're seeing with the stethoscope arriving moment. So what Obermann described in the 60s and 70s is that when people first arrive in an area, or when AI first arrives, there's this honeymoon period. Everything's great. Everything's wonderful. We really adopt it, and we're very positive around it. And then we develop anxiety. What does it mean in terms of ethics? What does it mean in terms of cost? What's my job? All of these kind of areas. And just for the purpose of this talk, we're not going to be going into economics and ethics too much. But you then enter this anxiety slippery stage, and then you start toying with it, adjusting it, seeing how it might help you for your setting, and then finally you accept AI. And what Gordon and colleagues argued was that we really are probably at stage 2 at the present moment. So we've not really kind of embedded and used AI in standard practice to the degree that we wanted to. We're still adjusting and playing with it, but there's a high degree of anxiety, and there are some who fervently believe that AI is nothing but bad, and some who fervently believe that it's a new dawn as well. So that's a good area to understand. But what I kind of think is, I think about AI and in the context of my background as an education researcher. And for me, it's low-hanging fruit. What's great about AI in education is that you haven't got the ethical aspects to a larger degree that you would say in clinical medicine, where you're dealing with real data, real patient information too. So I think that it's an open goal for us as education researchers, educationalists to actually study. But I'm speaking to the converted here. So yeah, that's exactly where we are, probably at that anxiety stage. Right, okay, over to the talk. So this talk is going to be in 3 parts, and I want you to remember that Tim Miller definition, which is it's about solving problems. And each part of this talk, I'm going to share a different quote, which I think is quite relevant. And this is a quote in relation to AI, which came from Harvard. And it said that when we begin with a technology, we have a solution in search of a problem. And this is the nub of the real challenge that we have. So according to Tim Miller's definition, it's around computer solving human problems. Now, what we often find is that we go for solutionitis, which is to say, oh, this is great, we'll do this with it. That's the wrong way around. So what we need to do is we need to absolutely have a very clear understanding of what the problem is that we're trying to solve, and then tailor the AI to it. So this is what we're going to do in the first part of the talk. We're going to talk a little about the problem that we're trying to solve, which is something that I've been working with Petal on, and which is what I call GerEd. So it's a bit like MedEd, but for geriatrics. And it's basically the problem is, how do we teach geriatrics in practice? So the first part of the talk, we're going to unpick exactly what that problem is. And then we're going to come to the part of the talk where I work closely with ChatGPT and think about future potential, and then think about share some human thoughts around the actual topic itself. Probably take about 45 minutes, Petal, actually. Is that okay? Yeah. Okay. Okay, so what's the case for GerEd? Going back to understanding the problem. And interestingly, if you're into education, there's a really good New Zealand education leader called Vivian Robinson, who describes how medical education leadership's around dissecting problems first and foremost. Well, okay, so if you just bear with me, and Petter will enjoy this being a old age psychiatrist, I'm just going to indulge a little bit about geriatrics. So this is a problem that we've got. We've got this huge demographic transition, which you guys know about. In 2000, 11% of the world's population was over 65, and now it's gone up to 22% for 2050. So 2 billion of the world's population will be over 60, whereas previously in 2000 it was 600. That's okay. We all know about that. Why is Andy going on about that? Well, the problem is twofold. The problem is, and this is a key thing here, that first of all, it's not just people are getting older, but people are getting very old. So in the future, the over 85s are going to increase by 351%, which is absolutely phenomenal. This came from the WHO 2010 report. So the actual nature of the people that we're going to see in practice is going to be so much more old and complex. But this is the key thing to just bear in mind. In the future, more older people are going to be cared for by less trained younger people. And this is really defined in what's called the age dependency ratio, which is the number of people outside of the working age who are cared for by those per 100 people in the working age. So at the present moment, or 2022, about 52 older people are cared for by 100 working age, and that's going up to 58. So this is the issue that we've got. We've got more people are being cared for by less. Just touching on that epidemiological transition. So you had that demographic transition when you got a rise in numbers. You had this epidemiological transition where the fabric of what we're going to see in clinical practice is going to change. So we know, for example, that the highest consultation rate for people to see their GPs are in the age bracket of 85 to 89. And I told you that the rise in numbers is 351% of 85 plus. So what that means is that GPs are suddenly going to see not so many young people, but a whole higher number of older peoples. So what does that mean? Well, it means that we're going to have a problem with upskilling in geriatrics in the future. And it's not just for geriatricians, it's not just for older psychiatrists, if you like. Everybody is going to have to get better at working with older people. There's a couple of ways around this. So one way to do that is to increase the medical workforce. So less people able to care for um, more older people. We can increase the numbers. But unfortunately, Queensland, which is a really beautiful place, and I'll plug that conference again, and the strapline for Queensland is beautiful one day, perfect the next. Unfortunately, we're going to see that we're going to have a shortfall of doctors. So even where we are, the workforce environment is less appealing, there's financial pressures, there's pressures to do well-being. So increasing the workforce is not the way forward. So what can we do? How are we going to manage this kind of silver tsunami, as it's called? Well, the answer is going to have to be better training in geriatrics. We're going to have to get sharper with how we train you in terms of managing older people. And here's a little meme here. You don't have to be crazy to work here. We'll train you. There will be no guarantee in numbers increasing. So that's the argument. That's the problem we're facing. That's why we have to actually upskill in older people's skills. A while back, Ellen Tullow and myself and Tien wrote an article about what the challenges are. What do we need to do? So going back to what's the problem, how do we actually kind of need to train up people in managing older people? Well, it needs to start at medical school, Michael. It's really important to start this early. Um, but the key considerations is that the training and education medically of older people is more around managing comorbidities, more around end of life care, more about communication, more about frailty, more about risk benefits, and being able to understand about atypical presentations such as falls and delirium in a collaborative model. So fundamentally, the way that we teach people now is going to have to change to encompass far more of those areas. So that's what we need to sort of target. However, the really sad thing is that what we do, we know from the literature, is that there's a decline in those key areas over the last few years. Um, Adam Gordon's done a huge amount of work looking at shortcomings in teaching. And what he's sort of identified is that there's a real tension because in medical school and elsewhere, we very much like to have a reductionist biomedical paradigm, whereas what we really need to be doing is teaching much more complex multimorbidity and frailty. Um, but what's absolutely incredible is that the amount of hours that medical students are exposed to learn about geriatrics is really very low. So the literature says if you're a medical student in the UK, you'll have approximately 55 hours of geriatric teaching, which is really insufficient to prepare you. Look, hats off to Canada. You're up there at 82, so well done, and you're a lot better than your US neighbours. So that's excellent news for Canadian medical students. But there are still gaps in teaching too, like elder abuse. But we're going in the wrong direction. We've not invested the time. Um, uh, and what is mad as well is that in the 80s, before we had this demographic epidemiological transition, we were teaching more in the UK, 68 hours in the 80s compared to 55 now. Obviously, that's a generalization, but that's, the direction of travel. Adam did he's the president of the BGS, so he did a survey of medical schools, and I know you have the number of 55 hours in 2015, and his conclusions are absolutely fascinating because he said that, less than 2 weeks of teaching really doesn't reflect the workload of people in relation to managing older patients, and we know that. But what he also did is he made a very astute comment, which is that, if you do medicine and you're teaching cardiology and someone who's over 65, that's not the same as teaching geriatrics. We actually need to refine how we do our teaching to actually promote understandings of frailty, complexity, cognitive impairment. So teaching with older people is not the same as teaching geriatrics. Interestingly, together with James Fisher, who Petal and I collaborated with, we actually did a study about 10 years ago now, looking in the UK at how much delirium's taught in medical schools. And this was a fascinating result. We found in 24 medical schools that we sampled that less than half of them, about 11, guaranteed exposure to an older delirious patient. Again, that's a worrying sign because what that suggests is that as a junior doctor, you're going to see a delirious patient, but at medical school, there is absolutely no guarantee that you will actually meet a patient who's delirious. Hopefully that situation is changing and hopefully it's not as bad in Canada. But taken together with a reduction in hours, a reduction in exposure, it is quite worrying. Okay, so this takes us to really kind of sort of the final kind of sort of article by way of understanding the problem. And I'm absolutely delighted to have worked with Petal and James Fisher, who did the previous article as well. And we actually worked with an intern called Chloe Yap. And what we did last year is we wrote a paper that was published this year in Asian Aging. And it was really to sort of try and redefine kind of sort of how we approach teaching around geriatric medicine. And it goes to that when we have a technology, we look for the problem. And we reviewed all the papers over the last 10 years in Age and Aging, which have been produced on undergraduate geriatric education and tried to look at themes. And what we're trying to look at was what were the targets for teaching? What were the papers telling us? And they told us that we needed to be teaching around collaboration. And that makes sense. So we need to be sort of scaling up teaching to teach around how we can build good collaborative care, because older people have complex needs. One person can't solve it on their own, so we need to work as a team. We need to be exposing more, and that goes to James's article. Patients with delirium have to be seen more by medical students. There's a massive issue around teaching attitudes, empathy, and ageism. The literature showed that we failed in undergraduate teaching because we don't actually address ageist attitudes. And then finally, complexity. So what does that mean? Well, it means that if we are going to bring in, an approach, it needs to actually hit these targets. Interestingly, an article also came out which did a little bit of the same of what we did, Petal, and it was a scoping review produced by Masood of Undergraduate, and they basically produced this word cloud, and they also were looking at, well, if we're going to teach, what are we going to teach? And it came out, as you can see, attitudes, delirium, curriculum too. So we've kind of sort of validated a little bit of what we're doing. So how do we go about it? Well, the traditional solutions are that interprofessional education is the way forward to build collaboration. Longitudinal clerkship's really important as well. If you see a patient at various times, you can understand the disease progression. Learning from patients, actually hearing about, how traumatic delirium and distressing is important. And doing joint teaching where a GP and a geriatrician can talk about how to manage complexity across discipline interfaces is a way forward. But the reality of it is that, placements are very difficult. IPL is hard to actually achieve. Clerkships are hard to plan. Patients difficult to learn from. So it's not easy. And that's why AI comes into the picture. So AI, we felt when we'd kind of written and reviewed the literature, may well provide solutions to these problems that we've identified. And that's why back end of last year started to become very interested in AI. And when I was asked to talk at the BGS, I said, well, I like to talk about AI and virtual reality in particular. So in a roundabout way, we've dissected the problem and we've landed at AI. Okay, so the second part of the talk, and like I said, I'll start with a quote. AI is not just a technology or a business trend. This is from the AI organization. It's a profound shift in how we interact. We're looking at moving from being tools to get to where we want to seeing AI as a teammate. And in the spirit of that, I basically just put the title of this talk into ChatGPT earlier on this year, and I said, can you list the potential for AI and virtual reality in geriatric teaching? And that really gave us a list of maybe seven different areas that it can actually help. So what I was doing there was I was using AI as a teammate to help generate, which was quite interesting, and that's what we're going to go through now. So I asked the bot, and the bot gave me some answers, but the bot will probably give me different answers today. And this is what we asked the bot, how can we do this? And here's how. The first thing is that it said that ChatGPT said that really AI can assist in creating immersive learning environments. And I'm really struck by this video that you put together, this simulation video. It's really high quality, and I actually played it at the BGS to show what good quality virtual reality is. We have our own virtual reality ones here, and one thing that I'm very keen to do in the next 2 or 3 years is to collaborate with the CAMH Simulation Center and develop virtual reality for delirium. So why does it help? Well, it helps because essentially it means, going to the problem that we created, it means that, one sec, just gotta, yeah, we can address the issue of unpredictable geriatric opportunities. So if one of the problems is that we do not have exposure to people with delirium and wards are very unsuitable environments to learn, we can actually bring the patients face to face virtually with the trainees in particular. The other thing is that we can actually learn from the stories of people with lived experience by using virtual reality. And that's really important because it addresses that kind of sort of ageist approach too. So typically, if I sit and talk you via PowerPoint around delirium and I mention it, you won't have the same impact. And then it also can develop empathy as it can put the actual learner in the shoes. Here's a video on the left that the Alzheimer's Society have produced in relation to dementia. It's not delirium, about an older person called Ted. It's a virtual reality. We can do better, I'm sure. just going on to this in the literature, what does the literature tell us? Well, the literature in dementia actually does say that there's an organization and they create virtual embodiment whereby you actually become the actual patient over time. I think it's called Beatrix. And I don't know if you're aware of the study from Virginia, but they did it with second year medical students and they showed that this approach was very effective in terms of developing empathy. And these are the questions that post the intervention, post the virtual embodiment, what comes to mind when you think about people with dementia and disease? Sad, uh, hard challenges. And that's really important because often we see in care that attitudes get in the way of good practice. So this shows you that virtual embodiment can actually address, and so that's a good way forward. Um, so that's the first thing. So probably the best one is that exposure, addressing that challenge. The second one is personalized learning. And I'm always fascinated at the way that it's going outside of medicine. So if you want to learn mathematics nowadays, you can learn that with Kim Kardashian, or you can actually learn it. I think there's a program whereby Taylor Swift and her American football boyfriend will teach you geometry. So we can personalize learning to actually make it much more effective actually for the learners. And that's really important with intelligent tutoring systems. There is some literature out there in relation to geriatrics. And this is a nice little study from the Journal of Biomedical Informatics, which is very far away from medical education, but worth reading. And it basically used an algorithm to support the evaluation of geriatrics patients. So basically, trainees inputted notes relating to, say, confusion or advanced directives, and then an algorithm sort of developed kind of sort of resources and approaches to personalize, feed forward future learning as such. And I think that's a very nice thing to do. We also do that also with our interns. Sometimes, you might wish to kind of sort of use a algorithm to feed forward to find resources to address learning needs. So that's another way to personalize learning. But interestingly, it goes a bit beyond that. So we know, for example, that um, uh, we know that one of the issues that we have is in regards to attitudes, and you can actually use ChatGPT to actually develop poems for patients with, say, delirium, and then they're not too bad actually. They're quite interesting, and that can be a great springboard for a really rich education session. So you can use LLM to make teaching interestingly more human through a very clever approach here. And this really turns this sort of quote, which is that AI can systemize the predictable to humanize the exceptional, on its head. So one of the big things, one of the big draws about AI is if it takes away all of the mundane stuff, we can do more human stuff. Actually, what I'm saying is that if you use AI in a very canny way, a very clever way, you can use it to develop some very human kind of sort of thoughts and ideas like poetry, humanities, um, to actually develop a much more humane approach to teaching. But then it goes beyond that. So I showed you the video of TED. That was an interest. Sorry, I didn't show you a video, but I showed you an image of TED, which is a virtual reality dementia teaching tool. But now with LLM, we can make things a lot more, and you probably know this, a lot more interactive. So if you get virtual reality and you add an LLM to it, you can get much greater yield and deeper learning. And here's an example here of virtual reality attached to LLM, which teaches how to actually respond to a aggressive patient in ED. And I think this is really important because what we're seeing as well, I was talking about the workforce shortages in many countries such as the UK. There are more medical students now. We're creating more doctors. So there's a real pressure on places, clinical places and hospitals. So if we actually make really interactive experiences, we can help overcome those pressures, and some of the learning can come outside of the hospital. This is a study that you're probably familiar with, and it compares physician and AI responses to patient questions. Um, And then it's been asked to, then people are asked to actually rate the degree of empathy. So to these responses, and it answers a question, which is that, can AI actually be empathetic? And in this study produced by Ayres et al. Last year, they showed that when questions were fed in, so patient questions were fed into the chat box, the results were rated as being more empathetic than when they were replied for by real life physicians. So don't think that we're kind of sort of going to produce a whole bunch of non-empathetic uh, bot-led doctors. Far from it. Actually, by using these LLMs to actually develop learning, empathy can still be preserved, and that's quite important for the problem that we're trying to fix. So we've spoken about how we can personalize learning. We've spoken about how VR can open up teaching areas. The other area, probably one for the future, and I'd be interested maybe in the discussion to talk a little bit more about this. I'm quite excited at the potential for using, headsets like Vision Pro to improve collaboration. So we already know, for example, in radiology, that few radiologists can look together at images and walk through them together in different spaces to collaborate. Now, if we think about IPL, that was an area which is a really important target. And IPL is really hard to do for a few reasons. We wrote a paper about this a few years back. It's a toolbox paper. And one of them is the physical need to get people timetabled in the same areas to learn together. So IPL is students from different disciplines learning with, from, and about each other to improve collaboration. That only happens if you're together. But unfortunately, most medical schools have difficulty achieving IPL because of the timetabling issues and the challenges associated with that. But what's really interesting, I think, is whether we can actually put our minds to using Vision Pro First Look to bring people together from different spaces and learn around maybe patients and learn with, from, and about each other, but not physically in the same rooms as such. ChatGPT then gave me another kind of sort of area that really we can kind of improve learning for geriatrics, and one of them is around teaching and accessibility. So there's a real workforce need to actually upskill in rural and remote areas, which aren't privileged to urban teaching environments. And what ChatGPT can actually kind of do is, not ChatGPT, sorry, what AI can do is actually sort of make teaching accessible to people in those areas. So this is using holograms. Holograms is an exciting way forward, whereby we can actually improve that accessibility, and it has been done effectively. Or maybe not quite as ambitious, we could use maybe augmented reality, which is not quite virtual reality, but it's really kind of sort of coming to life to actually learn. And what's an interesting application for this isn't so much about teaching students, but actually carers. So when we manage people with delirium, it's very important to actually upskill the carers as they know what's happening, and therefore they can contribute to the care processes. Um, One approach to do this was done actually in Brisbane by Christian Morrow. He used stroke education and he used augmented reality to give carers iPads to actually learn. And he did a study and he showed that actually you achieve much greater learning compared to, say, pamphlets if you used augmented reality. And that's really important, actually, especially for delirium, because we have delirium care standards, which probably not many of you know about in Australia. They're very exciting. They tell us how to do delirium best practice, but they're very hard to achieve. And one of the carer standards is around giving patients information and support, or carers information and support. And that's one that we really struggle with. But if we used augmented reality, a bit like in the stroke study, to upskill carers, it will be much more achievable and we can hit those standards as well. Number six, is ChatGPT suggested that AI can be used for real-time assessment. and look, assessment's absolutely key to the learning process. And I just share with you a couple of ideas around that. I know you had an excellent talk on using ChatGPT to produce rubrics for OSCE, so I won't go into that. But what you can do, and this is an approach that I've sort of developed through my interest in AI, is flip the classroom with ChatGPT as a teacher. What does this mean? So here's an example if you teach. You could, for example, have a session where you invite the learners into your room. You say, today we're going to learn around a topic of your choice. Um, and when I did this with my psychiatrist, they wanted to learn about covert narcissism. So it's really personalized. And we then had a kind of sort of brainstorming session where they shared what they knew about covert narcissism, and then we went to ChatGPT and we saw about whether we assessed what we discussed against ChatGPT. Now, some of what ChatGPT said was incorrect, fair enough, but that was actually really useful because it helped empower the learners. Said, actually, we know more about this than we thought, but we also need to remember about these different aspects. So what you're doing there is you're shaping teaching around what the learners want. You're asking them to sort of do retrieval practice, speak about what's happening, which is great. And then you use ChatGPT to assess in real time. And that's a really effective approach. And this is a quote from one of the registrars who said, this approach to flipping kind of the teaching and putting assessment by ChatGPT at the end makes learning very stimulating and interactive, a frontier that has potential to be more engaging than didactic PowerPoint slides. I'll be interested to hear if anyone online tried that approach. I mean, the other thing is as well is obviously we can use ChatGPT to actually generate MCQs at the end to stimulate retrieval practice, which is really important because we know from the education literature that embedding and laying down those memories cognitively is achieved through retrieval practice. So the final area that our LLM told us that geriatrics could be enhanced was in relation to lifelong learning. So I love this transition slide. On the left, anyone know who that lady is in front of the blackboard? Anyone of my vintage? Probably not. It's Doris Day, right? So Doris Day used to teach using chalkboard, but now we've changed to actually looking at the iPhone or a handheld phone as being the actual teaching teaching medium. So this is great. So, you know, I very much encourage my trainees to develop their own teaching with their learners. So, you know, they can sit down and I could say to them, right, I want you to learn about delirium, but rather than me teach, I want you to go away and just, you know, ask with this LLM to put together a teaching program on delirium. Um, if it's a bit light on communication, say give me more on communication, tailor it down to 60 minutes, give me a podcast, create some MCQs. So it does make to a degree the teacher redundant, but it also can enhance and supplement learning. So it's probably something that you do already, this AI precision learning, but it is an effective way. And I wish that when I was younger, we had this way to learn. Or, you know, there are apps that are coming out which are fascinating as well. So like there's a Socratic app here. It's actually quite an old one, but it will actually ask questions to generate learning rather than give you the answer. So we can now very much use apps technology to shape learning in an effective manner. Okay. So far we've defined the problem that we're trying to fix. We've looked at ways that AI can solve it. We've looked at 7 ways that, you know, we can achieve that. I'm going to sort of finish in the last 5-6 minutes or with some human thoughts. And I go to the final quote. I told you it's in 3 quotes. The real problem is not whether machines think, but whether people do. And that's a quote from Skinner, who's a psychologist. And that's absolutely the nub of the problem. So what I thought I'd do in the last part is to share some thoughts. Some of them you'll probably know, some of them might be stimulating about what the problems are and what my human thoughts are. So there's a lot of perspective articles out there, and this is a particularly good one from last year. And I guess my thoughts really are that we need to be very careful of shining new things. Just because you can use things you maybe shouldn't. I also think there's still a big need to develop AI literacy and digital maturity. And that we need to sort of think we shouldn't be worried about replacing. Everyone's got their job in medicine. There's always going to be a need to help older, sick people, but we need to think about supplementing and scaffolding. So just to the first principle, be aware of shiny new things. So look, these are pictures that I've shown you during this presentation. Um, they've been produced by Dali. They are rubbish. Honestly, I think that these pictures, I could have much better ways to do that. And this is the point I'm saying. Just because you can use DALI to produce images, don't, because they there's bias with how they actually do that. Um, so it's tempting and it takes a lot of time, but it doesn't actually enhance. The other one is the issue of hallucinations, which I'm sure you're aware of. I'm a massive baseball nut. Um, I know you've got the Toronto Blue Jays where you are, and I'm sorry that they're not in the World Series, but nor am I team, the Houston Astros. But anyway, I play with a team called the Rough Tails. Here we are, made it to the grand final in April. And I asked ChatGPT earlier on this year, what is a Redland Ray Rough Tails? And it tells me that it's a fictional Harry Potter team who play Quidditch. So they're completely off the mark, absolutely nuts. Um, if you look at it now, though, it's different. So it's actually caught up, actually. So they know who the rough tails are. But what they do is, as you know, these LLMs, you need to be aware that they amplify bias. There's a black box in terms of the data. And I think the way forward is for us to curate our own data systems rather than relying on other sources. Otherwise, we're going to have difficulties. So that's one area to think. There's other downsides as well. So I had a long chat about with Christian Morrow about his AI and stroke. And he said that the issue was to do with updates. Every year or two, he had to get updates, and it was very difficult, the cost, cyber sickness as well with virtual reality is something that you'll be aware of, and de-skilling too, as we become very dependent. So there are other downsides of AI. So that's the first point. Be aware of shiny things. The second thing is to develop literacy. And this is a study actually that showed that uh, medical students are very keen to learn around uh, AI. However, this is a Canadian study which showed that in 2022 in BMC, 85% of Canadian medical students reported no formal AI education as part of their curriculum. May have changed, which is great, but the problem is as low literacy really undermines use and leads to skepticism as to whether we can actually work with AI. And it's only by reading a lot about it that I've actually become this critical enthusiast. Brian Hodges, who many of you will know from Canada, wrote a really ahead of its time article in 2019 about how we should be learning from the story of Dorothy Vaughan, who upskilled in uh, programming in the 50s and 60s to help with the Apollo missions. We need to be going ahead of the curve to actually upskill to understand, because things are changing so fast, what's happening. Um, Rather than, and I think as well that we need to be collaborating a lot more with computer sciences too. The reality, however, is that medical school will assess you a lot more on your causes of rare conditions rather than your understanding of machine learning. So we do need a shift in how we actually sort of have our relationship with AI. And there's an AI curriculum that was put together. I think it's a medical teacher again, which is a great article here around what the kind of content of a curriculum is. And what you see is really interesting. If you look at what developing literacy is about, it's not so much about is developing understandings, but it's around following the actual pathway as to what's happening in the AI literature. Okay. And then finally, we need to be developing digital maturity. And by digital maturity, that's different to AI literacy. AI literacy is at an individual level, digital maturity is at an organizational level. So organizations need to be in a position to actually embed new approaches. And that's really important, I think, because there's a summary here on use of virtual reality and augmented reality in health education, and they said that they couldn't recommend the introduction of virtual learning in teaching and at the present moment because areas aren't set up for them to actually kind of deliver. So there needs to be this digital maturity that's actually taking place. But one of the key factors to think about when we think about upskilling is that it's very easy to be very critical, and it's very easy to say we need more studies to actually look at kind of sort of showing effectiveness. But I love this mantra, which some of you know probably, which is that the AI you are using is most likely the worst AI you will ever use. Things can only get more evolved in that sense. So don't put something on the shelf because it's told you that Rough Tales is a Quidditch organization. No, because it's going to get better and better. So that's the kind of maturity that's needed. In terms of supplementing and scaffolding, I do think we're in a place where we don't have to worry too much about being replaced, and it will free us to do more kind of human things. But the challenge is to think more creatively about what we do. How can we, use poems like I was saying to make humanities more present and say teaching around delirium. And this is another thing in terms of following and keeping up with the pace of things. I don't know if you're aware of Sora, but when this came out in April, this absolutely just blew my socks off. This is an AI generated video where there was a music video. I'll play a bit of it just because it's very nice and it's entirely done by AI. So I'll play a bit of it. I mean, I recommend listening to the whole thing. But what's amazing about this is what if we did this with patient experience with delirium? Rather than say, give me a music video around people on a bus listening and getting distracted. Give me an AI video on someone, what's the delirium experience is, and that's just fascinating that we can do that. All right, we do have a little bit of time for questions. Sorry, I have overrun a little bit, but just to conclude, first of all, we do know that there's a well-known gap relating to how we teach people around geriatric care, and we need to address this. It's really important for workforce reasons. AI does hold a lot of promise in terms of transforming, making education more engaging, personalized, accessible, but it won't solve everything. And ultimately, here's a chat from the Killers, Brandon Flowers, I think it's called. We need to be more human, as he says, about how we actually use AI and to think creatively in various ways. Where we're at, the scale of change is very dizzying, can be anxiety provoking, but we need to be sort of playing and toying and adjusting. It's absolutely crucial to upskill in terms of our AI literacy and the organization's digital maturity. And as teaching is a social intervention, ultimately at its heart as a social intervention, we need to view AI, VR, and other modalities very much as companions, so another player in the game. So that's the end of the talk. I very much like to thank Petal for inviting me, James, Chloe, and also Paul Tiffin as well for helping too. So happy to take any questions.
Thank you so much, Andy, for that brilliant presentation. I have to say, the turnout has been better for SimCity rounds, but I don't think the human capital could be any better in this rounds, because I'm proud to say the chair of my department, Dr. Benoit Lassant, has graced us with his presence, and as well as Dr. Sanjeev Sokalingam, who you are familiar with, I know.
Yeah, hi Sanjeev.
And I know that your last couple slides talks about organizational support and sort of the systemic issues that act as barriers to implement AI. So it's great that we have some of the movers and shakers here with us today.
Yeah, I can elaborate a little bit more on that one if you wanted to, but for example, one of my jobs is to look after it's nothing to do with geriatrics, to look after the interns. And we often have to put performance plans in to actually help the interns address their learning needs, which might come from multiple areas, MSF, EPAs, other areas too. And one way to do that is you could ask ChatGPT to develop a learning plan around all of these different sources, and it will come up with a great learning plan. But our organization is not ready to do that. We're not allowed to do that. There's too many legal aspects concerns around whether data is held and other areas too. So if as an organization we really upskilled, it could be a really powerful tool if we curated, brought into a chat GPT that we could use, which had this kind of security around it to make that happen. And that's what I mean about digital maturity. I am very keen to take something forward. My AI literacy may be good. Well, it's all right. It's not that good. But the digital maturity means that I can't enact it. And so there's a systems barrier. So we're very limited and spend lots of time writing learning plans, which are a bit incomplete. But I could feed potentially, anonymized emails and all kinds of things about a person's performance to come up with a really bespoke solution to link to resources.
It's a great point. And I think we encounter similar challenges here. Like if I were to build a scenario to help our psychiatry residents, for instance, get EPAs, which are entrustable professional activities, it would be nice if I could plug in the Royal College EPA learning objectives into the AI
Yeah,
to guide me. However, if you go to the Royal College website, there are, clear guidelines and restrictions against dissemination. And its use should be for certain things. And we know that when we plug things into ChatGPT or any of the AI LLMs, it can end up anywhere. So
absolutely. So you can't do that.
totally resonates with your example. And I have a hand up from Sanjeev.
Hi, Andrew. Sorry that I can't go on my video. I'm commuting right now, the joys of Toronto. But nice to see you and a fabulous presentation. My question to you is about the use of AI or ChatGPT in patient and family education, which you talked about in delirium. Could you elaborate more on maybe where we are now with the use of AI and creating and curating information for patients and families, and what maybe share with us a very cool idea that you've seen where an organization or institution is taking it to the next level for use in patient and family education.
Okay. Okay. Just to yeah, Sanjeev, great to hear from you. And just for those online, Sanjeev and I did a symposium today together on delirium in London over nearly 10 years ago. So patient education is really important for, especially for delirium, because you can have this aspect called indirect learning, whereby if we upskill the patients in understanding what should be done, staff will up their levels. And so that's one of the reasons why, in terms of kind of, we are very keen on why it's one of the standards for the delirium for the delirium care standards, as well as if patients, families know they're less distressed about what's happening, and also they're more able to contribute to personalized approaches to managing. We are unfortunately not very good at upskilling. We've done an audit where we are, and I showed you the results of it. We give information to patients which isn't appropriate for them. Sorry, to carers, which isn't appropriate. So I think you could use AI to actually think a lot more and generate kind of, a leaflet that is much more friendly and in tune with the needs of an audience that we're not familiar with. So all of the patient information pamphlets that we give are very kind of sort of over medicalized, if that makes sense, and very scary. So you can actually, have a medical pamphlet and then say to ChatGPT, can you write this in a tone which is more friendly or less concerning too. So that's an example perhaps about how you could use AI to do that. You could do the augmented reality if you've got the ability to do that, but on a sort of low level scale, that's something we potentially could do. We haven't really taken it that far. The reason for that is because education is often the kind of sort of soft last option. So where we are, our focus is very much on getting people to actually do 4ATs and screening, and much harder and easier to measure. So I unfortunately wish I could give you an organization which kind of sort of has used AI to improve their carer information, but I haven't. I'm not in a position to do that. But I work, much more in the delirium field now as a president of the association. So potentially we might maybe continue the conversation, Sanjeev, and think about how we can specifically do that. But there are focus groups led by Alison Mudge and others which do show that patients struggle with the information they're given. So that's where AI can help.
Thanks, Andrew. And I do wonder, building on some great points you made, whether we could train AI or ChatGPT as an example for to be a little bit of a coach to curate that information that you talked about for family
Absolutely.
members who are observing their loved ones struggle with delirium, for example, something that we may not have the nursing staff or medical staff to do, but something that maybe could be augmented as part of care.
So Sanjeev, it's great having a conversation, because I never really thought, put my thoughts to that as an area, and maybe thinking about this AI and delirium symposium that's going to be occurring next July in Cairns. That's something that we might put out there and explore further, and you're more than welcome to come to that as well. So yeah.
I'll always accept an invitation to Cairns. Thanks, Andrew.
Yeah, get your scuba diving kit. Right.
Any other questions? Benoit, I'm talking to you. It's all good. So I was thinking, yeah, like when I go on my phone provider, my internet provider is Rogers, and when I go on their website to look at my bill and whatnot, I see AI pops up. I assume it's AI, right? And it's conversing with me. So when I think about giant hospitals like the one I work at, with multiple siloed disciplines, geriatrics, child, addictions, you imagine that might there be an opportunity for AI to direct you, like if you went to the website and answer some questions you might have.
To help navigate the system.
Yeah.
Hmm.
And connect you to resources, to that curated pamphlet you referred to, right?
Yes. Yeah. Absolutely. No, that's absolutely. I think that's right. I think that the challenge that carers have is with managing the system and not feeling like some kind of a. I remember a guy called Engström, who's a medical education researcher from Finland. He said that the patient's very much kind of like a sort of letter that just goes past from place to place, and they don't understand. So yeah, and joining up, but perhaps AI can help join. What we've done actually here at the Prince Charles is we've set up an AI special interest group, not just on education, on the back of my reading, and it's really small, but it's grown and it's become very organic, and that's the kind of solutions that we'll be looking at. And it goes, we have junior doctors who are really good at programming, and IT very literate, and older people who've got a lot of experience. So yeah, if you create that moment of bringing the people, they might come to make that happen. Yeah.
Well, if we don't have any more questions, I'm just checking the chat to make sure. Andy, it was an absolute pleasure to have you here at our SimCity rounds, and you've given us a lot to think about. And I think as we embark on this journey with AI as our teammate, as you put it, and VR, I think that there are bright things ahead. So
no, Petal, yeah, no, I'm delighted, and thanks for the questions, and it'd be great to continue the collaboration. Certainly the VR kind of in delirium is an open goal in particular. So I look forward to that, and thanks for your attention.
Okay. Take care, everyone. Thanks for joining. Bye.
Thanks.